Robert is Assistant Professor of Peds at Emory University and Associate Director of Hemostasis and Thrombosis and Clinical Director of Operations and Research at the Hemostasis and Thrombosis Program at Children's Healthcare of Atlanta, and he has become a national expert in hemophilia carriers.
Thank you. Thank you for that nice introduction. I was sort of thinking about the title, and the uterine hemostasis colloquium is sort of a very intimidating title, and that, you know, and also the fact that with many movies and other things, the sequels aren't often as good as the original. But I think in this case, I think the sequel is better. I think this has been a fantastic set of talks. Maybe you could switch it to The Uterus Strikes Back or something like that. So we can think about that for the third installment. So my task is to talk about the hemostatic challenges in pregnancy, specifically on women with hemophilia and those that are carriers as well. And so, you know, these are my disclosures, but my most important disclosure is I'm not an OBGYN, and I don't try to claim to be. I do prescribe birth control pills in my clinic, and something that I've sort of learned over time how to manage just because of the lack of ability, you know, the availability of GYNs in our local area. So again, we'll start with a case. This is a 34-year-old, and this was a patient and a mother that was taking care of their child while I was at Vanderbilt University. She was 7 months pregnant, and she was actually the patient that described her bleeding symptoms to me that led me down this path of trying to describe the bleeding tendency in carriers. And it was her rebuke of my teaching that carriers don't bleed that actually led me down this sort of path. And so her levels were, you know, lower prior to pregnancy, and, you know, our sort of recent data would suggest that it's important to do a one-stage and a chromogenic assay to look for any potential discrepancies. We've seen this pretty recently, and if you participate in the My Life, Our Future, you'll see, I think those results hopefully will come out from that group. But her current level is 45%. It's always sort of, it's like the Risto. When I saw your Risto, someone always has to have a Risto of 45%, just to make it a little more interesting. And so the question often comes up is, which mode of delivery would you recommend? And I actually attempted to do this in sort of a cost utility analysis methodology, because we're never going to do a randomized study for this. And it's something that's quite difficult to do. And there are some obvious options. You could do a planned C-section, a vaginal delivery. You can do a vaginal delivery and early conversion to C-section. Those are definitely potentially options. And so, you know, so this little bit of background, you know, when we talk about carriers, we know that there seems to be a normal distribution curve that's shifted to the left that seems to show that the levels are closer to 50%. If you do the larger studies, certainly the majority of the patients have levels in the 40 to 60% range. And then the non-carriers, it's a little closer to the distribution of 100%. The classification is, you know, continues to be controversial. If you want to irritate a group of women at a meeting, use the term symptomatic carrier inappropriately, and you will definitely piss off a lot of women. So one of the tasks that we've sort of had, and we're going through ISTH, is to sort of rename this, and we'll talk about this. But certainly if somebody has a level internationally less than 40%, in the US less than 50%, you should refer back to the severity system that we utilize in men. And so I think it's appropriate to take the term back, symptomatic carrier. I think it's an appropriate term to use in those that have levels above 40 to 50%. Again, internationally, they're going to sort of make that cutoff 40%, but I think most of us in the United States know the right answer is 50%. When you look at the Athens data set, you can see here, by far, obviously, when you look at women with bleeding disorders, and this is as of early this year, von Willebrand disease comprises the largest portion of the pie. But if you look at the carrier status here, you can see the vast majority are hemophilia A carriers. It reflects what we see normally in the males, the significant higher prevalence. And the majority of the patients are in the mild range. We have a few patients that are in the moderate and severe range. There are a few patients with Turner syndrome that I've taken care of in our practice. But there definitely is there are a lot of patients, and they're typically between, you know, 20 to 50%. That's where a lot of those patients reside. And this data would not have been successful without the My Life, Our Future project, which was quite critical. And I know that there's a project, Dr. Johnson's going to have some data coming out on this, hopefully later in the year or early next year. So one of the sort of tasks that we wanted to come up with is, what is the appropriate name? And so certainly there are carriers that have levels that are a little bit higher, but they have some bleeding tendency, or without a bleeding tendency. So I think it's certainly okay to use that term asymptomatic hemophilia carrier. And then there are times in their lives where they may have more challenges and they may have more bleeding symptoms, because I think this is a dynamic thing that shifts over time. And using that term symptomatic carrier, I think, is appropriate. At least that's what we're going to suggest. And so far, NHF and HFA have been okay with this nomenclature. And then I think if you're talking about levels in the mild range, you should use the term women or girls with mild hemophilia. I remember, I think Peter was there when I was at the ISTH women's session. A lot of people had some problems with the term women and girls, and so I didn't mean to put quotes around women and girls with hemophilia. I was just referring to the population, because I think the preference is to use that term, women and girls with hemophilia, versus females with hemophilia, which is the less preferred term. Roshni will explain that to you, so I'll just put it on you. And then certainly if the levels are in 1 to 5%, you would use the term moderate hemophilia. I think certainly if you're having discussions with the genetic counselors, you can use the term hemophilia carrier as the first term that you utilize. But when they're in the emergency room, they're engaging with other physicians, I think it's more important to emphasize the fact of what their level is, because even when I looked at this literature, I had to go back to the manuscripts because they lump everybody in the same category. And certainly a carrier with 5% level in the third trimester versus 120%, those are radically different patients. And so that's where I think the struggle is in the data. And our colleague here did a nice review with Dr. Conkle that I read last week. So, when it comes to optimal mode of delivery, these are actually some really nice, they don't do this a lot in hemophilia, but this was a really nice sort of manuscript battle here between Dr. James and Dr. Leung. And I can tell you, Andy, when I sort of initially read this, I actually was leaning toward more of use the vaginal delivery. And over the years, I've sort of come around to the idea that cesarean delivery may be the optimal mode. So it's taken me about 9 years to come around to that. So, but if you look at the arguments in favor of vaginal delivery, obviously there is an inherent risk of intracranial and extracranial hemorrhage. This has been well described in multiple manuscripts, most recently in the CDC that Roshni published. And so, if you look at those numbers, you can say, well, the vast majority of patients don't get that. But if anybody's ever taken care of an intracranial hemorrhage, I mean, that's a lifelong problem. And that patient, you see these patients at clinics, they don't grow, they're in a wheelchair. I mean, that's a devastating outcome and a long-term sequelae. This sort of thing, it's interesting when you look at this sort of general trend. When I was starting to do the vitamin K deficiency bleeding, I felt like I got sucked into all the discussions about cesarean section and vaginal delivery that I did not want to have discussions about. And the problem is if you have taken that task that you say, I want to do vaginal delivery, and I can always change my mind later. The problem is if you look at the risk, there seems to be a higher risk of intracranial hemorrhage, and you don't know exactly when the point of no return is and how early do you convert. And so certainly there's a concern that the risk is higher if you do that strategy. So when you're talking about cesarean section, I mean, the risk can be reduced now near 0%, around the 0.6%. And the problem is if you look at that data, they're including those patients that were initially vaginal deliveries and then converted. But if you look at the ones that had scheduled C-sections, the rate is quite low and can be significantly low. Although we had to have a case at our center in which somebody used a vacuum extraction to remove the baby, which we told them later sort of defeated the purpose of doing the cesarean section. And of course they had they had an extracranial hemorrhage, and then the story, factor replacement and inhibitor development. So, despite the high rates, I think, again, the long-term complications of even a small intracranial hemorrhage are quite large. You're talking about the entire lifespan of additional health care that patient's going to have. And so, when you talk about this, though it's interesting, when you look at the European guidelines, they've generally favored vaginal delivery, and I think it was mostly based on these Swedish registries over 20, 30 years. And it's always remarkable because when you look at these sort of places, I mean, the entire state of Georgia has as many deliveries as, the country of Sweden. And I think it's interesting that we're basing a lot of our information on a relatively small European country. But when you do surveys in these countries, you can see the trend of being more conservative and favoring cesarean section. And so I think you won this battle, Andy. It was a long-fought battle over 9 years, but I think you've beaten Dr. Leung on this, and you've definitely converted me on this idea. And so when you take that into account, you look at the most recent MASAC guidelines, which was updated in the last few sessions. Things that you should do, you should obviously have a good plan in place. I think making sure you identify these carriers. There are quite a number of women that somehow make it all the way until the point of delivery before we get the phone call. And somebody says, well, I looked at the charts and, we noticed that her grandfather has hemophilia. And so having that expertise, and that means genetic counseling, having that available, having the blood bank expertise, and obviously having a hematologist nearby. I don't think it goes without saying avoiding instrumentation. We should not be using forceps in these situations. Certainly the vacuum extraction is going to increase the risk, particularly of extracranial hemorrhage. And then, I think this plus or minus on, I couldn't really find really good data on the fetal scalp electrodes. I think it's just more common sense. I'm not, what go ahead. We don't use it as muff. Okay, yeah. Okay. I don't think it probably conveys that high of a risk, to be honest. But there will be a sort of a risk of scalp hemorrhage. So I don't think that's, I think that one's a little bit more of a call locally, whether it's needed. And then the option of a cesarean section should be recommended. I feel like that's like the most wimpy statement you can get. The option should be recommended. So just say we recommend it. So they need to be more direct. But I think that sort of is the general recommendation. Obviously, there are quite a number of carriers that show up and you're not aware of the situation and they don't have their family history that's well known. So going back there, I think sort of when you sort of talk about this, doing the planned cesarean section makes sense. That should be the recommendation. Obviously, the woman can make the decisions about whether they would like to attempt that, and certainly.
For the woman anticipating delivery of an affected baby.
Yes, exactly. So yeah, and certainly in the United States, it's not always clear. That's where the problem is. In other countries, they're doing more fetal sex determination, and maybe this is happening more in the United States and more centers. And so that's where sort of it gets a little bit difficult. Obviously, if you know what the child is, and of course, if this is a female infant, then you don't need to do that. But you can certainly discuss that because there potentially is a higher risk for bleeding for the mother. So the other question that comes up a lot, and this was sort of, I think, some of the impetus of what Andy's work was done in the von Willebrand patients is, the epidural block, because the last thing you want to do is this woman having a discussion with an anesthesiologist about how he's not going to do regional anesthesia. So that's not the timing, the optimal timing of that discussion is at the time of delivery. And so, there are quite a number of options you can do. You could do recombinant. Certainly you can do plasma-derived concentrates as well, so I didn't mean to not list that as an option. You certainly can do antifibrinolytics, and I debated about taking some of this tranexamic acid off of after that discussion yesterday, so it was a very effective discussion. But remember, that wasn't in women that are carriers. And there are patients, we still see this where they're getting cryo and plasma. I think most of us would say that's the wrong answer. So when you look at coagulation changes during pregnancy, certainly factor VIII rises during pregnancy. Von Willebrand factor also concomitantly rises. The debate about factor IX, whether it rises, I think statistically it rises slightly, but we're talking about a fairly incremental rise. And so if you look at here over the boxes, the average rise based on this nice set of patients, this is still a fantastic manuscript from Dr. Chi back in 2008, there's about a threefold increase in the level of factor VIII. But remember, people like Andy will tell you in a normal woman, the level at the third trimester is often over 200%. And so we don't know if there's some evolutionary benefit for having the level that high. And so I think that's where some of the debate comes, whether you should supplement with factor concentrate. And certainly in factor IX, the level only moves slightly up. It's almost sometimes within the coefficient of variance. And so you should not expect a significant rise. And most of us, and most of the guidelines suggest, doing a level in obviously the non-pregnant patient, the first trimester, early third trimester, because you never know about prediction, and your center may not be able to turn around those factor levels quickly. And so this is something to sort of think about. And then obviously you could do one closer to delivery. I don't think that's quite necessary because the level is likely not going to be much different. And this is also in regards to, we don't know what happens immediately after birth. There's almost no data on this. I couldn't find any manuscripts about what the levels happen after the delivery. And so I think a study like Andy did years ago with von Willebrand patients would be welcomed in this population. I know it's very difficult to do practically. So when you look at primary and secondary postpartum hemorrhage rates, and we had the discussion about the proper definition for primary and secondary postpartum hemorrhage, and some of the groups seem to use a fairly liberal definition, and certainly this group has been criticized. I think it's a Dutch group, Stoof et al., of using a fairly liberal, sort of liberal definition of postpartum hemorrhage. But I think it's probably safe to say it's somewhere in the 10 to 20% range. And again, we're putting all the carriers in one bucket, right? We're putting carriers with levels that are high and levels that are in the lower range. And so that's sort of the problem. We don't have really good longitudinal data. But there seems to be a trend that there's a higher risk for postpartum hemorrhage. And so having the appropriate care nearby is important. So when you talk about management general of bleeding, I think most people say this magical level of 50% is what we should shoot for. We think that's probably the appropriate level. Using factor concentrate certainly is something you should consider prior to procedures, prior to any delivery. It's after that, above that, we don't know what to do, particularly if there's bleeding. We know that mothers are skilled, and so if it's needed to give it at home, these mothers are giving factor to their young children. So you should sort of take advantage of that ability. And I can tell you, based on some research studies that we've done in which we've tried to do chart reviews and medical claim reviews, a lot of these women are utilizing factor at home. They're not getting it through regular prescriptions. They're getting it through other means. And so they are well experienced in doing this. And so it's going to be really hard to characterize their use. DDAVP certainly could be considered in carriers. I think you have to think about the volume, whether there's going to be uterine tonics used, because as many of you know in here, there's at least 2 to 3-fold increased amount of fluids given in those given C-sections. And so you have to think about that fluid restriction difficulties in this and whether you want to do that, or would you just be safer just to go with the factor concentrate. I know they use DDAVP a little bit more in Europe than we do, and they feel like it's quite a safe way of managing it. So, when it gets above 50%, that's where it gets difficult. So if you have a carrier that's bleeding with a level above 50%, that's where it gets a little bit challenging, and that's where probably the sort of careful use of antifibrinolytics makes sense. There's very, very little data, as you summarize in these very short sections of that paper. You can summarize all the data on one little column on the carriers on management. So again, when you go back to the MASAC guidelines, which attempts to summarize some of this, when you talk about neuroaxial anesthesia, we have to sort of lean on our experience of the men, right? Men have gotten these sort of blocks, and they seem to have very good outcomes. I could not find any reported bad outcomes in those that have levels above 50% when they're supplemented. So certainly we would think the same would make sense for the women. And it's important to understand, you need to sort of maintain that trough above 50% during the entire time. But as I showed you, the vast majority of women typically get their levels above 100% or close to 100%. And so that shouldn't be an issue. But it's really important to have documented factor levels so you're not having a fight with the anesthesiologist. So I think it makes sense, in this patient, there's sort of this borderline level, the potential terrible outcomes of an epidural hematoma. I think it makes sense to do an infusion, and that could be either plasma-derived or recombinant in this patient, and certainly would be the same if they're a hemophilia B carrier. And then you need to maintain the trough level above 50%. That's where I think people forget that it's not a one-time deal and then you walk away. And so, depending on the length of delivery, you need to continue that until that catheter is removed. And I could not find any data of how long after the catheter being removed. I think it's reasonable probably to give a single dose after the catheter is removed, but there's zero data to support that. I think that's sort of best practices. So what about peri-partum care? Again, summarized nicely in this manuscript. DDAVP, we know that it seems to give a 2 to 3-fold increase in the factor rate. There have been a few case series, very small case series, in which 1 to 2 doses were used successfully. Again, factoring in the fluid restriction, which typically is restricted to less than a liter in 24 hours, which is not a lot of fluid when you're talking about a pregnancy. There's some magical formulas that you can use for this, but it's typically about 2/3 of the maintenance fluid for a day, but obviously that's different when you're talking about a pregnant woman. There's very limited data to support the use of it as a prophylactic to prevent postpartum hemorrhage. And again, you know, if their level is 50% or higher, you can say, well, that's pretty good, but that's not normal for a normal pregnancy. And so again, we don't know where to go. I think it's sort of the same debates about fibrinogen in pregnancy as well. When it comes to factor use results, there's some mixed results. There's some this consideration about using with antifibrinolytics. You obviously have to factor in the risk of thrombosis in these patients. We don't want to also have to do postpartum prophylaxis with any anticoagulants in this population. So I think careful, small doses in the immediate peri-partum period is important, and watching closely. And I think really, to be honest, heavily relying on the uterotonics. If you look at that, that's probably where you should start with, and then consider these as a sort of a secondary. And particularly those with levels above 50 to 100%, I think you have to be very careful. Antifibrinolytics, there's almost no evidence about using it alone. I think a lot of us use it in clinical practice, but we don't all publish this data. And I think we really do need to have some sort of longitudinal study looking at this. And I think the challenge of this is that these women don't deliver in academic institutions. So they're not delivering at our centers. They're delivering down the street at one of the non-academic centers. So we have to come up with a strategy of how to do registries in which they aren't coming to our center, because that's where the challenge is going to be, and I think that's something we should approach. So certainly, if there's any, this is a nice chart that Mauser bin Schotten put together in the title of Symptomatic Carriers. It's a little bit odd the way she has it, but these are patients less than 60%, because the perception is based on multiple studies that the bleeding tendency seems to become reduced once you get a level of 60% or higher. So she has it sort of set up this way, but certainly you could give concentrates, and she gives suggested doses there as well, and could, consider the use of tranexamic acid in DDAVP, particularly those that have levels in the moderate to mild range, particularly at the end of the 3rd trimester, and only relying on factor concentrate, because DDAVP has no role in hemophilia B carriers. So in an ideal world, you want to determine the genetic status. We always say that. We always have cases in which we don't know that genetic status. I feel like at least once every other month we get a phone call, a frantic phone call. Genetic counseling should be offered. I think most GYNs have those readily available, and during when they're getting their counseling. The multidisciplinary team is very critical, having these discussions, because the patients can be unique and you have to factor in multiple situations. It's important to acknowledge that the factor levels rise during pregnancy, and factor IX doesn't really rise significantly, and so you should acknowledge that and sort of set expectations for that mother in the 1st trimester early on, so we know what's going to happen. And then really think about factor replacement if there's procedures, deliveries, and maintain that trough above 50%, because a lot of the guidelines forget to mention maintaining the trough above 50%, because it's often not a one-time deal. That epidural is going to be in for a while, the length of the pregnancy. And then I think that goes without saying, avoiding instrumentation. You definitely increase your risk significantly if you use vacuum and forceps assist. And then there's a little bit of debate about the fetal scalp electrodes. It sounds like we're not using them quite as much, but I certainly think that they're not as much. That's more of a call locally. And then I think, the debate about sort of the optimal mode of delivery, I think it makes sense to really suggest cesarean section to the family. Obviously, there may be women that decide to go vaginal, and certainly we have women that deliver at home, and other sort of, that's a sort of a trend we're seeing throughout the country. And so sort of having this discussion is important with the family, because it seems like there's a lot of changes in this in the last couple of years. And then we don't know exactly how long do we need to maintain the level after a vaginal delivery or a cesarean section. The data suggests maybe 7 days for cesarean section and maybe 3 days for vaginal delivery. Most people are not in the hospital that long afterwards. I'm not aware of anybody that keeps their patients that long. And so I think this is an area that's worth investigating, getting levels post-pregnancy if that's something that's feasible. I'd almost have to send out a home nurse to go get those levels. but I think generally trying to keep the levels in that range, because certainly those women that have postpartum hemorrhage develop anemia and then have issues with breastfeeding, it becomes very difficult and it becomes emotionally disturbing to a lot of the families. If you ever go to these patient meetings, they talk about that, about the deliveries, issues postpartum. So there's lots of resources listed here. Obviously, Foundation has a great website. And so, I'm just here to sort of illustrate the data, and I think at this point we're happy to take questions about any of the cases. So thank you very much.
Grabowski. So thank you for that presentation, Robert. A question for you is, in the carrier woman who delivers a baby, and you do a vaginal delivery,
Sure.
and then because it's a carrier, you do a PTT and you find it quite elevated.
Yeah.
Therefore, you presume you do have hemophilia. Can you justify doing an MR to look for bleeding? That is to say, susceptibility weighted.
So in the infant you're talking about?
Yeah.
So we actually did do a cost utility analysis on this, and you can sort of, it's sort of an emotional issue more than a sort of a mathematical way, but we thought this study is never going to be done. And it seems like based on sort of a long timeline, that if instruments were used, then you certainly should consider an MR. There's some debate, and I think there's a strong suggestion now, and I think some of us are shifting that way, that any child that's born with severe hemophilia should have a head ultrasound. That certainly misses some of the posterior side, but I think if there's no instrumentation, the likelihood it's not going to be in that location. So at the minimum, an ultrasound makes sense.
Right.
But when we looked, if there's instrumentation of difficult labor, it sort of shifted, and it made sense to do an MR.
Right.
If you want the mathematical answer, yes. So.
I think the ultrasound will miss parenchymal hemorrhage in many
Sure.
cases. So
Yeah.
it's maybe more of an insurance question.
Sure.
But it seems reasonable.
Yeah, I think the ultrasound probably should be universally done. We sort of shifted into doing that. It's not based on a lot of data, and you saw that data was 2 to 4%. That's certainly not a very high percentage, but the implications are high.
Yes.
Development of inhibitors is a concern.
Okay, thank you.
Yeah.
In the first case, Andy, Dr. James, if I may ask you, was the assay used for heparin level, was that a clotting-based one or chromogenic?
At the outside hospital, I don't know.
The reason I'm asking is because if it's a chromogenic assay, it really underestimates the true heparin level. So at our place, unless you have, like the second case you had was a homozygous AT3. We've had 2 cases now with teenagers with AT3 levels in the 40 to 50% range, and we can quite well get therapeutic heparinization without using AT3 concentrate. And we've been fortunate that we have an assay called a liquid 10A assay, which is clotting-based and utilizes a patient's own antithrombin 3, as opposed to the pooled donor antithrombin 3, which is added to the chromogenic assay, which have been used in the past. But with this, we're able to monitor our heparin levels and add the amount of heparin we need to get truly therapeutic. And we've done okay with those 2 cases. The difference between the chromogenic and the clot-based ranges from 15 to about 30–35%. Depending on the range of therapy.
Thank you for sharing that.
Thank you, Robert. You said it took you 10 years. It's taken me 20 years to come around, and I've been on MASAC arguing with this. But I'm wondering if this is a great opportunity for us to pull data to think about stratifying our carriers before they're even pregnant.
Sure.
Should we do a DDAVP trial to look, per your wonderful collaboration with the Kingston group, that the carriers, maybe with even the asymptomatics above 50, may even be bleeders at delivery if they have a poor DDAVP response. So
Sure.
should we stratify them based on their DDAVP response and their bleeding score? And either or, if they're abnormal, what would you then recommend prophylactically at delivery in terms of tranexamic acid or trying to raise the level, beyond, 100%, beyond 50% to a physiologic level?
Yeah, so what Peter's referring to is the study in which we were looking at why women with essentially normal factor levels bleed. And one of our hypotheses is that their ability to raise factor VIII is reduced compared to normal women. And that was a study that we did with Paula James and Victoria Candy, and we demonstrated that that was actually true, that their ability to raise factor VIII and sustain it is reduced. So we're trying to follow that up with exercise studies to see if that is sort of the same, and their ability to respond to stress. I think probably their ability to raise it during pregnancy. I think we'd have to answer the question, is that also a surrogate for what happens during pregnancy, that their ability to raise their factor VIII is limited, and certain ones may bleed more because of that limited rise. And so I think that would be a good study to sort of look at, sort of to try to stratify those patients, because I think it's more complicated than just the level is this and you should supplement. I think there's some modifiers that we haven't been able to figure out, but we just did that finding, and so I think it makes sense to go back and look at pregnancy outcomes and what was done based on their DDAVP response. But the problem is a lot of those women have not had a DDAVP challenge. And so I think that would be an interesting study to do and encourage our colleagues to do those challenges, to have that option so we can actually collect that data retrospectively.
Oops. Hi, Meera Chatlur from Wayne State University in Detroit. Thank you very much. Sorry. Thank you very much for a wonderful conference and a great meeting so far. And sorry for dropping the mic. So I just wanted to say a little story to maybe highlight a point. This was a baby that was born about a year ago now. And based on, this is just to highlight that we make our recommendations based on gender of the baby that's being born. And maybe we need to rethink, especially in this forum, considering we're saying that carriers can bleed. Maybe we need to rethink how we make our recommendations based on gender. So this was a girl that was born obligate carrier because dad has hemophilia, severe hemophilia A. Obviously the father forgot to tell the gynecologist that he had hemophilia. The baby had heel stick bleed, had a vacuum extraction, and developed a little hematoma there, and they were watching it because they didn't know that there was a potential for a bleeding disorder. Had prolonged bleeding from the heel stick, and then the nurse was having trouble and mentioned that, this is taking longer to stop than it should, and the grandmother happened to be there, and she said, "Oh, my son has a bleeding disorder." And they said, "What?" And she said, "Hemophilia." And of course, everybody panicked. And the baby is a baby girl and has a factor VIII activity of 10%. So she actually needed factor to get rid of this extracranial hemorrhage that she had. So now I actually have started to rethink what I say to the mother when I know that this is an obligate carrier. I don't necessarily say, "Oh, it's a girl, it's okay," anymore. So, and I think maybe we should have similar recommendations, even though it's a girl, that you don't do a vacuum extraction, you don't put fetal scalp electrodes, you should consider a C-section early on. So I actually have changed the way I say it. I say that I know this is a girl, and the likelihood is less, but it can happen, so I would follow the same guidelines for everybody.
Oh, your point is very well taken. I have to interject here. And we do that kind of counseling. We have the anticipated male who's like, you need a C-section. And then we have the anticipated girl where we think the phenotype's going to be a little milder, but more like potentially von Willebrand disease. So our EPIC dot phrase is the same as for von Willebrand disease, which says, avoid vacuum forceps, scalp electrode, get 2 blue top tubes at delivery.
Yeah, thank you.
Can I just ask really quick and throw in there, we're so nonchalantly throwing out the C-sections here. Has anybody ever looked at women with C-section versus non-C-section and how they're doing later on in life?
So just in general, in terms of not in women with bleeding disorders, there's actually been 2 randomized trials of planned vaginal delivery versus planned caesarean delivery. And one of the reasons that my hematology colleagues are loath to plan for a cesarean or recommend it is that they are committing the woman to greater bleeding, greater risk. But in fact, planned vaginal delivery includes the risks of failed vaginal delivery, which are much higher than the risks of a planned cesarean delivery. So there are 2 randomized trials. One was in breech and one was in twins. And if you combine the maternal risks of bleeding for planned vaginal versus planned cesarean, they were no different except the risks of bleeding were slightly higher in the planned vaginal group in the twins.
But that's bleeding. What about later on, right, that, or, I don't know, abdominal pain or scar formation, or I don't know. I mean, has anybody ever followed these women a little longer?
Probably, we don't see differences. Probably they've not been reported, and probably comparable because we're probably back to the risks of unplanned cesarean or failed vaginal delivery are significantly higher than a planned cesarean. So when you combine that risk with, when you combine planned vaginal delivery that includes successful vaginal delivery and failed vaginal delivery, which is a more complex C-section, then those risks are probably equal as in bleeding, as in other maternal complications like clots and et cetera, which were equal.
And I agree that it's a little bit more nuanced. So we did have one case, and these are pretty rare. A woman had a child with Turner syndrome, so had severe hemophilia A, a massive intracranial hemorrhage, and died, and then had a subsequent child. Shar knows who I'm talking about. So that had Turner syndrome as well, and we were prepared the second time around. I mean, those are obviously exceedingly rare situations. The child developed an inhibitor that we tolerized. So we do have to think about those sort of exceptions. But you saw the numbers of patients with moderate and mild, severe deficiency are quite low in the United States, and it comprises a very small portion of the hemophilia carrier population. So.
Hi there. Also in regards to the last presentation, so I'm from the University of Vermont. We're a very crunchy bunch, and this is near and dear to my heart because every time we have a patient, we have a robust hematology and maternal fetal medicine conference quarterly, and we fight about this to the death every single time. And as I recall, when we pulled the data, the risks when you remove the cases where assisted vacuum and forceps deliveries were removed, it's my understanding that it's not clear sort of where the risk-benefit lies. And I just want to make a comment that when we think about individualizing care and you have a multiparous woman who's had 3 or 4 vaginal births, which sometimes does, previously undiagnosed or whatever, and it's totally different from somebody having their first baby, perhaps they're older, very high risk of cesarean, and in the end as well. And we have a patient who's a repeat offender who's had now her 4th child, and was diagnosed as a hemophilia carrier after her first son was diagnosed with hemophilia. And she has opted to move forward with vaginal births regardless of the gender of her baby, and she would be, literally on her 5th cesarean in that scenario, which gets to future risks, secreta, abdominal placentation.
Yeah, it's hard when you look at that risk. The risk for planned C-section, if you remove all those, vaginal deliveries that got converted, is very low. It's like 0.6%. It's really what's acceptable risk to the mother as long as she's informed and understand that. Because we had the same issue when we were in Nashville. High decline rates of vitamin K. They have that farm group nearby, a lot of the home deliveries, and so we had a lot of discussions about this and a lot of negotiating with the families to try to protect the child as much as possible. So I agree. It's a long discussion.
And we still offer those women cesarean delivery, being less anxious if they choose to have a vaginal delivery, like our last patient with factor IX deficiency.
Just bringing up an article from 2007 by Gilmore, who's a psychiatrist and actually was at North Carolina and decided to do MRIs of normal children without any bleeding disorder, and he found 26% of them in this group basically had bleeds. Okay, and then some of them were children of schizophrenia because that's what he was interested in studying, but another group that he was comparing it to had mild ventriculomegaly.
What I take home from those data is that vaginal delivery is hazardous to the baby, but in a baby that's hemostatically normal, it will be fine. But if you have an underlying bleeding disorder and you have that challenge, you will not necessarily do well. You don't know, your body doesn't know when and how to stop bleeding.
I would like to know what the neuropsych is on those kids 10 years later.
I think they're doing a study on that.
Novo Nordisk has a e-think study in which are the neuropsych exams in normal patients with hemophilia, mild, moderate, and severe. And so we might be able to get some long-term neuropsych outcomes on that, so.
Hi, my name's Laura from Henry Ford in Detroit. I'm a nurse practitioner, pretty new to the hematology world. And I just had a few comments. I attended the first colloquium 2 years ago, and at the time we had 3 patients who were pregnant. 2 had levels less than 10%, and 1 was about 40. And they went into term or preterm labor during the course of the conference. I have to still thank Dr. Kulkarni and Dr. Coides because they were like giving us direction from Arizona about how to manage that. And one of the things that we did, one of the moms was a multip, and really we treated her, and she had such a remarkably improved postpartum bleeding event experience. And she told her sister about it, so of course we covered her sister as well. So that was just a way to kind of see the action from this group. I wanted to ask Dr. Jarris about the spontaneous abortion on the patient that was on the Tretinoin, and was that different from her previous miscarriage experience?
All of her, they were all, I mean, we didn't have any ultrasound, I didn't have any, did not happen under my care, so I don't have a lot of information what happened during the previous miscarriages.
Right, but you had the hemovolemic shock, or
Yeah, the hemorrhagic
for the
shock
fifth,
happened,
and then
exactly.
And then the 6th, you were treating her. Was
Right.
that miscarriage less bloody?
It was less bloody, so she definitely did not go into hemorrhagic shock, plus she had been on the Tretin, so.
Right, I just
you know,
wondered if there was-
It was just a miscarriage, and she didn't have any abnormal bleeding during that.
And then regarding the patients with C-sections, I can't imagine our anesthesia team just blissfully signing off on regional anesthesia for our patients, because they currently are super hesitant. Even with platelets under 100, they're like, no.
Yeah.
So I was just wondering if you'd had challenges with getting anesthesia to be more interested in this?
Yeah, I mean, it's obviously dependent on the location. I think that's where the hematologists need to have a good relationship with the anesthesiologist, show their internal data, and demonstrate it has been done before, because obviously that becomes a big conflict at the time of delivery.
Right.
When, you know, like a 25-year-old resident's coming in and saying we're not doing it. So, you know, and so so yes, there have been places where we've had that issue, and it often requires talking to them, you know, outside of that sort of time period, and showing the data and demonstrating it can be done. And then also saying that you're going to be available and take responsibility as well, because they feel like they're taking on all of the risk and that we're not going to take it on. But clearly it's a shared responsibility, so.
Well, and I would say sometimes it doesn't matter whether you have an experienced hematologist that has a plan and you give factor, the anesthesiologist will still not be willing to do anything, and
been-
sometimes you need to transfer the patient.
Right. And then finally, just to comment on Dr. Chitler's story, so we have the dad of that little baby girl, and I can tell you that we did discuss with both dad and mom that they needed to let the team know, but mom was, she had had other babies, but not with our patient, and she didn't have a high degree of expectation that there could possibly be a problem, that this would affect her baby, because she knew it was a girl. And so my guess was that even though we encouraged her to let her OB know and talk to the team ahead of time, she didn't have a lot of interest in that. So it's just so interesting to hear the other side of the story. And you know, you say to yourself, should we do the sideways thing and call that other provider and say, listen, your patient has X, Y, or Z, or, you know, anyway, it was just interesting. Thank you.
So we did some data that we haven't published on health literacy and numeracy on this, and I think we assume that they understand these risks, and when you talk about probabilities, and the numeracy of the carriers and the men are below average. We think that our community is well educated, but when you start going down to and you talk about probabilities, and they actually have tests where you do this, and it's actually a very poor understanding of simple genetics and that. So I think part of it is that.
So just this thing about the future, I think a lot of these women, when you expose them to factors, are really pups. You know, they are previously untreated patients. And so we really need to keep a track of what happens to them, because one of the mothers raised this, she was factor 9, had retroplacental hemorrhage. And And I didn't know whether to give her regular factor 9 or, FC fusion. There are no studies, really. Nothing is available. And there's nothing about non-factor therapies in these situations, whether that can prevent hemorrhage in both the mother and the baby, even though one of the non-factor therapy for AIDS is approved for all ages, including babies. So I think it just opens up the field to think about these mothers and babies and perhaps, have new studies which will address these issues.
So this is really interesting, and I wonder whether that therapy crosses the placenta.
So just a follow-up on Laura for what you commented. So what we do when we actually do prenatal counseling, even though we are a pediatric center. We have the parents come in, we sit down and talk about the possibilities. We have a little kit. So we have a letter to the OBGYN that has the MASAC guidelines on it, has a phone number to call, has our laboratory number on it, and we give 2 blue tabs that go into the kit. And so they take it to the OB, and it goes into the mother's chart. So something to consider. And we've, so far, had good luck with this process, so.
Hi, my name is Amber. I'm a nurse practitioner from Nevada. And I just wanted to make a comment on some of the nomenclature because you're going to get into a whole lot of dialogue with the community, and I've been in some of those with you where women can get quite passionate. We've not had much success at our center with preserving carrier, asymptomatic carrier, symptomatic carrier, because it causes too much confusion in the community amongst our other colleagues, our ER physicians and onward. So we actually started using hemophilia trait, and we started explaining it in terms of other benign hematology conditions where the trait is present, but it doesn't necessarily mean that those other traits can't have iron deficiency anemia, or we need to be cognizant of the possibility. And that for us seems to have made much more progress than preserving the carrier. The carrier just has way too many things attached to it for healthcare providers and then patients alike. So I just wanted to share with the group that our luck with using hemophilia trait and whether or not we then do mild hemophilia for underneath, it has been actually more beneficial for us.
Yeah, and it would be interesting to see what physicians in the ED think about when you use the word trait, because that to me that conveys there's no risk of anything to the patient.
When
as
we've
well.
asked our local ER docs, they actually felt that carrier conveyed no risk and that trait actually caused them to call us. So I guess it would be regionally specific.
Hey, I have a question about the, John Beckman from University of Minnesota, about the factor 13. Using the Trenton product that doesn't have the factor 13B carrier subunit, have you checked your patient to see if the level of the clearance is different when you're missing that B subunit?
No, I haven't, and that's a really, really good point, but no, we haven't. It's so hard to get levels.
Mm-hmm.
And we don't do them at our lab to begin with, so they're a send out, and so it's almost impossible.
Are you dosing based off
but
of
we can change that.
antigen, or are you dosing based off antigen levels, or what's you do the urease test, or?
But for the screening, and I don't know, it's Dynacare, and I don't know what they did. Actually, I don't know. There are various ways to determine it.
And then I was interested, your patient had a preference for a recombinant product versus a plasma-derived. What was that conversation?
We just laid out all the options,
Okay.
and said, these are the potential ways of raising factor 13. We definitely think we need to do that, and this is what's available.
Okay.
So.
Thanks.
Just a comment about Dr. Kudis's comment. With regard to DDVP challenge as a way of looking at potential utility in the peri-partum period of time for carriers. In 1985, there was a paper published looking at, I guess you'd today called a Walmart version of determination of hemophilia carrier state before genetics were available. And it was using DDVP challenge to identify carriers on the notion that factor VIII level is always very variable depending on numerous factors, but that post-EDVP you're measuring, if you will, the total body exhaustion of the product, which is determined by the number of affected cells. So it turned out that it was a 95% specificity and sensitivity for factor VIII levels that were less than 100%.
problem with that study was that they didn't have a wide variety of patients with levels that were in a wide range. And so they didn't have patients with levels very low. The majority were very high. And so I think there probably isn't that much difference. But I know the paper you're talking about, because there's not that much literature on carriers, so there's only a few, but I know what you're referring to. And remember that at the time they were exclusively using one stage, and also in that manuscript, they had issues with doing these challenges in different locations, and they got quite different results when they shipped them over to different locations. So
That must be a different paper than the one I wrote, because we did them all in our center. I don't know. We just did it in Manitoba, but we just did it in Winnipeg. We didn't do it anywhere else. So maybe there's another paper. I don't know.
But there wasn't a wide variety of levels in the carriers. You didn't have patients that were like 5%.
No, we
and
had like,
patients that were, yeah, exactly.
no, we had 20 to 80%. Yeah. But the mean was 50%. But anyway, the point being that maybe in somebody who's, they say, oh, by the way, I've got an uncle who has whatever. And it may also be predictive, as Peter was suggesting, for hemostatic risk.
Sure. It's worth looking back, yeah.
Well, thank you very much for staying till the end of the program. We have 30 seconds left, and we'll dismiss 30 seconds early. On behalf of the Board of Directors of the Foundation for Women and Girls with Blood Disorders, we appreciate your attendance very much. I want to thank our wonderful speakers.